my institute. So background of botulinum neurotoxin is it is a microbial protein that exists in 8 serotypes A to H, and it is introduced 28 years ago, and it became an effective treatment of numerous movement disorders associated with increased muscle tone or muscle overactivity. The ability to block the acetylcholine release at the neuromuscular junctions accounts for its therapeutic action to relieve dystonia, spasticity, and related disorders. And mechanism action is, it blocks the release of acetylcholine from nerve endings, which was elucidated in the mid-1900s. Since then, botulinum toxin A and B are food and drug administration approved in USA. And this is the normal neuromuscular junction where there is a release of the acetylcholine, and botulinum toxin blocks the release of acetylcholine. The next here it blocks, and once after that also there is regeneration of the nerve endings, and again it functions normally. So it takes around 6 to 9 months for the regeneration of the or start functioning of the neuromuscular junction. So botulinum toxin, it is a Clostridium botulinum. It is anaerobic bacteria, and it causes deadly poisoning. All of you know it is botulism. Botulism neurotoxin is the most potent poison known to mankind. Even 39.4 gram can destroy the whole universe. And my topic should be indication how botulinum toxin A works, and evidence to support the use, and methods to inject, case studies and limitations. And indications are spasticity in adult and children, strabismus, blepharospasm, cervical dystonia, focal limb dystonia, axillary hyperhidrosis, tics and tremors, neurogenic detrusor dyssynergia, and chronic unilateral low back pain. So why botulinum toxin in cerebral palsy? Most common symptom of cerebral palsy is muscle stiffness resulting from spastic movements. And children struggle with their movements to varying degrees and may even experience pain with these spastic movements. About 75% children with cerebral palsy suffer from significant pain, and sometimes injected to know about the surgical plan, who sometimes inject preoperatively whether the soft tissue procedures work or not to assess that. And these are the increased muscle tone, which leads to muscle contracture and then lead to bony liver arm dysfunction. And in this phase, spasticity control phase, is botulinum toxin can work. After that, when there is contracture, lengthening or deformity correction. So these are spasticity and muscle shortening and joint contractures. The quantified spasticity quantified by Ashworth scale, or modified as Ashworth scale or Tardieu scale. And this is the to know the hamstrings. This is the R1. This is R2. So this range is spasticity range can be elicited. R1, R2. So hamstrings can be, spasticity of the hamstrings can be known. Then also in this is to know about the ankle, R1. This is R2. R1, R2. So this is the spasticity range. So botulinum toxin causes temporary chemodenervation. Selected overactive muscles are weakened or paralyzed, leads to redistribution of muscle forces across the joint, and reduces the spasm associated with pain relief, and because therapy becomes easier. So the development of therapy become easier. So specific indications on upper limbs are, it prevents the contractures, it enables the grasp and facilitate release, and repeated to teach grasp, release, synchrony, and hence transfer of objects. It can also help in prejudging the efficiency of the tendon transfer. So what is the evidence? Spastic cerebral palsy, early studies suggested that it is an alternative treatment for an equinovarus deformity and obviate the need for surgery prior to gait maturity. Since that time, 80 articles have been published discussing the use of botulinum toxin in the management of cerebral palsy. So in Equinus, there is 4 class 1 studies into the gastrocnemius, improved gait over 3 months. Class 1, class 1, 2, class 2 studies evaluated the efficacy of different doses. In all these 3 studies, the highest dose was most effective, 24 or 30 units per kg despot, or 200 units of botox regardless of weight. Hamstrings to small open label class 4 found modest improvement in either gait kinematics or hamstrings length with injection into the hamstrings. Adductor spasticity also one class 1 study, injection into the adductors and medial hamstrings showed improvement in knee to knee distance and decrease in adductor spasticity. And another class 1 study evaluated the need for post-operative pain control in children undergoing adductor or adductor muscle lengthening. Upper extremity goal for injection of the upper limb include the relief of the spastic posturing and improvement of upper limb function. Two small class 2 studies and one class 3 study addressing the use of upper extremity described modest improvement in tone and range of movements without demonstration of significant functional gains. So to conclude, the evidence botulinum toxin injection of the gastrocnemius soleus muscles is established as effective in the treatment of spastic equinus in patients with cerebral palsy. There is insufficient evidence to support or refute the benefit of additional casting to injection of the gastrocnemius soleus and hamstrings. And in adductor spasticity, injection is probably effective in improving adductor spasticity and range of motion as well as post-operative pain. In patients with upper extremity symptoms, injection is probably effective in improving spasticity and range of motion. So prerequisites are spasticity Ashworth grade 3 and above, spasticity or dystonic, ideally spastic hemi or diplegic cerebral palsy, behavior intellect should be good, hand function should be useful, there should be voluntary and grasp and release to gain maximum from the botulinum injection, and always re-examine the child before decision is taken. Steps are, we have to locate the muscle, locate the maximum concentration of motor influence, and injection techniques like dose and dilution. So dose is it diluted with 0.9% sodium chloride, and 2 ml diluted, 100 units diluted because 100 ml vials are available. It is injected 2 ml, so that 0.1 ml contains 5 units. And doses don't exceed 400 units and once in every 3 months. Localization by surface marking or EMG guided or ultrasound guided. Surface marking, Despond et al. Unipenetrate muscles. Bulk of the muscle mass is maximum concentration of motor end plates. And bipenetrate muscles, these are more even distribution throughout the muscle. So for example, this is gastrocnemius muscles. They are injected in 3 sides, bipenetrate muscles. So they are injected into 3 sides. Doses are also, these are all available in the how much doses and which sites all can be found in the literature. A number of sites if you see in the upper limb, biceps injected 4 sites, other all muscles are 1 site. In the lower limb, hamstrings, gastrocnemius, soleus and tibialis posterior 3 sites, flexor hallucis longus and flexor digital longus 2 sites. So this is by the surface marking technique, we can feel the muscle, so injection can be given. So electrodiagnostic, there is a nerve stimulation, we need a nerve stimulation very cheaply available also within 4,000-5,000 rupees. It is a peripheral nerve stimulation, stimulate the specific muscle, which progressively, once you stimulate, it progressively decreases the amplitude from 1 to 0.5 and at times 0.1 it can be stimulated so that at that site injection can be given. Ultrasound guided injection allows precise disposition of toxin to desired sites and maximum utilization of toxin and decrease wastage, decrease chance of treatment failure and less time required for the procedure, which decreases pain and distress. These are the injection of ultrasound probes and these are small insulin needles. And there are 2 types of technique. One is in-plane needle placement technique. In-plane is preferred because it allows visualization of the entire needle. And out-of-plane placement, tip of needle is visible within the target structure which has not passed through it. All the muscles can be identified like all the upper limb muscles and can be surface marking by ultrasound. All can be identified by practice, and lower limb muscles also can be by ultrasound we can identify and inject in the proper places, either it is unipenetrate or bipenetrate muscles. Small muscles like adductor pollicis in the upper limb can be identified and injected. Difficulty psoas muscle, I have not injected in psoas muscle. Psoas major is injected just adjacent to the anterosuprailiac spine with the needle directed 45° medially of the anterosuprailiac spine and swept through a 30° arc proximal and distally, in which psoas major can be also injected. So this is a case where this is a hemiplegic child, this is a gait analysis. hemiplegic child, 6 years old. After the injection follow-up, sorry. So advantages are it is effective, it is selective, reversible, safe, preventive, corrective and adjunct to the other surgeries. Adverse event, some safety well documented for the use in children with cerebral palsy, pain, redness, irritation of the injection sites, sometimes fever, weakness, dysphagia, incontinence due to systemic absorption which is very, very rare, no toxin-related death or anaphylaxis reported yet. Contraindication, myasthenia gravis, sensitive to albumin during aminoglycoside antibiotics, simultaneous use of non-depolarizing muscle relaxants, and its caution should be in bulbar symptoms and frequent chest infections or gastroesophageal reflux. There are some non-responders because there are some neutralizing antibodies are there, they are non-responders, which then this occurs due to frequent injections, large doses, early initiation, males or booster doses or number of sessions more. Thank you for a patient hearing.